On. We have started the recording, sir.
Good
Okay.
evening, everyone. Here comes another session of education and knowledge from none other than our beloved teacher, Dr. Abha Majumdar. Today, the topic is quite interesting, intriguing, and we would learn from her about the endocrinopathologies which impact fertility. Over to you, ma'am.
Thank you, Tejashri. As usual, it is so good to be here. And I really wish all those girls who had requested for this topic should join in, because I think one girl had asked me last time that she wants to know about medical disorders, but we are more concerned with endocrinopathies rather than medical disorders like hypertension or other problems. However, we will concentrate on four endocrinopathies: the thyroid gland, the pituitary gland, the adrenal gland, and the pancreas. So we would discuss all these four endocrinopathies today in our presentation. So when we look at thyroid disorders, there are two types of thyroid disorders: hypo and hyper. Thyroid gland is situated where you can see in the picture right in front of the cricoid process, left and right thyroid gland, and it is joined together by the medial, two lobes are joined together by the medial stalk. So when we say hypothyroidism clinical classification, then there is a primary subclinical hypothyroidism where we have high TSH, but T3, T4 is normal. And T3, T4 are the active hormones which come from the thyroid gland. And hence, even though the pituitary is sending higher amount of stimulation to the thyroid gland, still T3, T4 are adequately produced. Then comes overt hypothyroidism, where TSH is high, but on the other hand, the T3, T4 are becoming lower because the thyroid doesn't have the capability of secreting more than what it is secreting, despite more stimulation coming from the pituitary. So overt hypothyroidism is true hypothyroidism, where you have deficiency of T3, T4. And then there is a third type of hypothyroidism, which is secondary or also known as central hypothyroidism. Why does this happen? Because there is a problem in the pituitary. The TSH is deficient, and therefore it stimulates the thyroid gland much less than what it should. And the T3, T4, TSH all are low. So if you really want to rule out central hypothyroidism, it is good to do all the three hormones, T3, T4, and TSH. Once you've ruled out central hypothyroidism, then your follow-up can be just with T4 and TSH. And here the free T4 is most important than the total T4. Having said that, let us see what do we do. What is subclinical hypothyroidism? This is the most common type of hypothyroidism which is prevailing in our people and which we encounter in our day-to-day practice every day. So subclinical hypothyroidism is defined as TSH level greater than the upper limit of normal range in normal people. And the normal range is generally 4.5 to 5 MIU per liter. And here T4 levels are normal. The normal reference range for TSH changes in pregnancy. Why does it change? Tell me. It changes because there is HCG coming from the pituitary, and that simulates TSH to some extent. And hence that beta HCG is also stimulating the thyroid gland, and hence enough thyroid is being produced, and there is a negative feedback on the pituitary, and the TSH becomes lower. So the upper limit of normal in most laboratories is, like I told you, 4 to 5 MIU for non-pregnant women. But in the first trimester of pregnancy, TSH should be as low as 2.5. It is higher than that. That means there is something wrong, and the stimulation of thyroid is not enough by the beta HCG plus TSH, which is being produced in pregnancy. So because beta HCG is a co-worker with TSH, and hence TSH levels should go down. And if they do not go down, that means beta HCG is not enough, and we may have to give a little thyroid replacement to the patient. The prevalence of hypothyroidism is about 13% in Indian population and more common in females. And this is from Dhanwal, who has done extensive work on thyroid in pregnant and non-pregnant women in India. So how do we screen? This was American Society for Reproductive Medicine 75th Scientific Congress and Expo in October 2019. Universal screening starting with T4 and TSH. So the first screening should be with both of these, and follow-up can be done with TSH alone during pregnancy and women attempting pregnancy. So there are two categories of women which we'll find. One who come to us who want to get pregnant, and the other one who are naturally pregnant and they come to you. And you need to look at the T4 and TSH levels. So it is recommended in all pregnant women who come to us and all women who want to get pregnant and come to us, because India is a high prevalent zone for hypothyroidism. Thyroid antibody testing, TPO antibody testing, is not routinely recommended in women planning pregnancy or seeking infertility treatment. When do we want to do TPO antibody? I'll tell you later. No difference in TSH values if blood is drawn in fasting versus non-fasting status, whether it is drawn in the morning versus afternoon. So this is very important take home, which I want all of you to know, that please do not send a patient back for a blood test on another day, because once we had thought that TSH should be drawn on fasting blood samples, but that is not so, and it is not even morning samples. We can even take it on an afternoon sample. So what is pregnancy screening? The National Guideline for Screening of Hypothyroidism During Pregnancy, India, 2014, were laid down, and this is as below. First trimester cutoff is 2.5, second trimester is 3, third trimester is 3 MIU. During pregnancy, if TSH level is more than 10, irrespective of this, that T4 is still normal, it is considered overt hypothyroidism and has to be treated very, very effectively. So treatment is what? Levothyroxine is the drug of choice. Levothyroxine sodium belongs to a category A for using during pregnancy, and it can be used safely during pregnancy and lactation without any adverse effect on mother or fetus. Overt hypothyroidism should always be treated. There is no question of not treating it, which means in pregnancy, either the T4 levels are low but TSH levels high, or the TSH levels are more than 10, even with the T4 normal, should be treated. Once biochemical euthyroid state is reached, TSH can be repeated after 6 months. This is for a non-pregnant woman. So testing for thyroid antibodies. Thyroid autoimmunity is the most common cause of hypothyroidism, which we all know as Hashimoto's disease, and has been independently associated with miscarriages. So I do not know how much this holds true today also, because a lot of randomized controlled trials were done later on, and it was found that antibodies are not associated with increase in miscarriages, which is significant. So testing for thyroid antibodies is not routinely recommended in women planning pregnancy or seeking infertility treatment. When do you do it? It should be considered if TSH is more than 2.5 on repeated occasions, or other high-risk factors for thyroid disease are present, staying in iodine deficient area, or there is genetic history of Hashimoto's, then one has to go. If TPO antibodies are detected, TSH levels should be followed even if they were less than 2.5 earlier. So what is subclinical hypothyroidism in the infertile female population? What does the guideline say? The practice committee of ASRM says this guideline was made because of the controversy whether or not to use first trimester pregnancy thresholds for upper limit of TSH to diagnose and treat subclinical hypothyroidism in women attempting pregnancy. So all this was made that she's not pregnant as yet. There's no beta HCG. So why should we look at lower TSH levels? She's just attempting pregnancy. So the controversy came up that should we treat women who have a TSH of 3, 3.5, 4, 4.5 when they are attempting pregnancy. But subclinical hypothyroidism defined as TSH more than 2.5 and less than 4 with a normal T4 is not associated with infertility or miscarriage, but there is fair evidence that subclinical hypothyroidism, defined as TSH levels more than 4, may be associated with miscarriage. So if you want to keep a good eye on it, then only treat it if it is between 2.5 and 4. It really doesn't require treatment. But if you know that she's undergoing IVF, ovarian stimulation, then maybe it is good to start treating them even when the levels are 4, 4.5. So what is this line here? Acha, sorry. So if what do we do if the woman is undergoing infertility treatment? If TSH more than non-pregnant lab reference, typically more than 4. Most lab references are 4, 4.5 or 5. So if TSH is more than that, treat to maintain levels to less than 2.5. So if you're starting treatment and they are high, more than the lab reference levels for non-pregnant people, you start treatment and you aim to keep it less than 2.5. But if TSH levels are between 2.5 and 4, monitor the levels. Don't start treatment immediately because she's still not pregnant and the levels are less than 4. So if they are more than 4, you can start treatment and bring it to less than 2.5. If they are between 2.5 and 4, you can monitor, and as soon she become pregnant, you can see them again. Test for TPO antibodies only if repeated TSH values are more than 2.5 or other risk factors, like I told you, are there for thyroid disease. This is grade C evidence. If anti-TPO antibodies detected, treatment to be considered if TSH levels are over 2.5, even in non-pregnant women. So with TPO antibodies, TSH levels over 2.5, start treatment. If the levels are between 2.5 and 4, you don't need treatment. If the TPO antibodies are not present. So you only do TPO antibodies when you find repeatedly TSH values are high and there is a family history of Hashimoto's disease. Means the patient tells you mother is a hypothyroid, sister is a hypothyroid, there are multiple people, or she's living in a iodine deficient area. Women undergoing ART IVF, what is anti-thyroid, what is the thyroid guideline? Women undergoing IVF-ICSI with subclinical hypothyroidism should be treated to achieve a TSH concentration of less than 2.5. So when you are starting COH, controlled ovarian stimulation for IUI or IVF, it is pertinent to do TSH levels. And if they are even between 2.5 to 4, please not fertility patients who are attempting pregnancy, on you can leave on thyroid after is finished, because it is difficult to interpret results during controlled ovarian stimulation back, which goes up and there's a positive hormone surge. So all the gonadotropins, as well as the thyroid stimulating hormone, the gonadotropin stimulating hormone, everything is changing. In non-pregnant women with mild TSH elevations following controlled
Ma'am, there seems to be a problem with your connection.
2 to 4 weeks, because levels may. So having said, now these are to understand only pregnant, 4 and T5 at 2 or more occasions, or she has high risk factors. During pregnancy, the cutoff of TSH is 2.5, and above that, it should be treated as subclinical hypothyroidism. Those planning pregnancy should be treated if TSH levels are more than 4 MIU, and then TSH levels should be maintained to less than 2.5. Monitoring with serum TSH after 6 weeks of initiation of therapy is important. So is this very clear? The guidelines, I think, should have been very clear. In pregnancy, 2.5 is the cutoff. In women who are planning, it should be less than 4. But if you are starting treatment, aim to bring it to less than 2.5. What is overt hyperthyroidism? This is characterized by suppression of pituitary TSH because there is a lot of serum T4 and free T3. What is subclinical hyperthyroidism? When TSH alone is suppressed in presence of normal serum T4 and T3. So serum T3, T4 are absolutely normal and TSH is very low. Say it is 0.05 or 0.5. Both are low. In this, TSH has been suppressed and T3, T4 are still in the normal range. What is the prevalence is about 1%, less than 1%. So hypothyroidism is 13, 14%. This is just around 1%. And so overt hyperthyroidism always treat, which means T4 is less and TSH is, T4 is more and TSH is less. Subclinical hyperthyroidism, treatment not recommended, but you need to follow them up to see whether T4, T3 started going above the range where they should be. What are the drugs used? Two drugs, propyl thiouracil and methimazole. So let us see the differences between the antithyroid drugs. These are the two drugs which are available. And propyl thiouracil decreases thyroid hormone synthesis. Methimazole also does the same. Propyl thiouracil, in addition, inhibits the conversion of T4 to T3 also. Now, propyl thiouracil crosses the placenta less readily, whereas methimazole crosses placenta more readily. So methimazole crosses the placenta and goes to the fetus. And methimazole is associated with a rare embryopathy, which comprises of aplasia cutis, choanal or esophageal atresia, which are really lethal for the baby. Whereas propyl thiouracil can be associated with maternal hepatotoxicity in 0.1 to 0.2% of pregnant women. So we have to weigh the two drugs. So treatment in pregnancy, if possible, anti-thyroid drugs should be avoided in the first trimester of pregnancy, especially if there is subclinical hyperthyroidism. But when it is clinical overt, then PTU is generally favored because it does not cross the placenta and it does not have an embryopathy effect. PTU is recommended for treatment of hyperthyroidism through 16 weeks of pregnancy. Why is it so? Because it is hepatotoxic, and in 1,000 women, one could get hepatotoxicity. So we feel that once the embryopathy period is over, then we can switch over to a drug which is not hepatotoxic. Pregnant women receiving methimazole who are in need for continuing therapy during pregnancy should be switched to PTU as early as possible. However, my endocrinologist informed me about a year ago that now we are using methimazole in the first trimester also, and with very little chance of embryopathy. However, these are absolute guidelines, and if tomorrow a baby has a problem and you're using methimazole, we could be under scrutiny. When shifting from methimazole, because this is a drug which is commonly used for women, then what we do is the dose ratio of, how do you change the dose? So if she's on 5 milligram of methimazole, then the dose ratio is 1:20. She will go on PTU 50 milligram twice a day. So 5 milligram daily to PTU 50 milligram twice a day means 100 milligrams a day. So that is how you shift or you decide the dose from MMI to PTU. Antithyroid drugs in early pregnancy. If antithyroid drug therapy is required after 16 weeks gestation, it remains unclear whether PTU should be continued or changed to methimazole, as both medications are associated with potential adverse effects, and shifting potentially may lead to a period of less tight control. No recommendation regarding switching antithyroid drug medication can be made at this time. Consideration can be given to discontinuing PTU after the first trimester and switching to methimazole to decrease the risk of liver failure in the mother. So this is important that we have to understand. And as most of our fertility clinicians also see pregnant women after they get pregnant, at least for the first trimester, a little bit more, it is important for all of us to know it. And as obstetricians, we all need to know this. Now we come to hyperprolactinemia with infertility. Establish hyperprolactinemia as a cause for ovulatory dysfunction, then only start treatment. I always say this to all my juniors that please do not just start giving cabergoline or bromocriptine only because you find one high prolactin level in patients who are absolutely regularly menstruating and ovulating. Progesterone, how do you know that this hyperprolactinemia is pathological or not? You do a progesterone level on day 21 to 25 of a cycle. If P4 levels are normal, means generally more than 5.5 or more than 8 nanograms, then there is nothing in the ovulation which is being harmed by high prolactin levels. And if ovulation is normal despite higher prolactin levels, consider this as macroprolactinemia, which has no biological significance. In asymptomatic hyperprolactinemia, estimation of macroprolactin can be done using polyethylene glycol precipitation test. If we start asking our laboratory people to do this test routinely when they get a high prolactin level, it would be very nice that, they can give us that after using this estimation, hyperprolactin, the normal prolactin value is this, and the remaining is of the macroprolactinemia. Then we know macroprolactin molecules, or the big molecules, have no biological function or very little biological function. So how do you define hyperprolactinemia? It is defined as more than, most of the laboratories have 20 nanograms per ml in men and 25 nanogram per ml in women. It could be a little different from laboratory to laboratory. And this is important, that this should be done at least 2 hours after waking up. Unless prolactin levels are markedly elevated. And when we say markedly elevated, 2.5 times the upper limit of normal. And if upper limit is 20, then 50 is the 2.5 times upper limit of normal. Repeat before labeling as hyperprolactinemic. Even one normal value considered normal, an isolated raised one can be discarded as spurious, because prolactin can rise even if you burst a cracker near the patient when she's giving blood, the prolactin may go high. So if the value is normal, so there was a lot of controversy that pooled samples should be done, and then we find that prolactin is normal. But you don't need to do, because every prick when the patient has pain can increase the prolactin levels. So the higher one is discarded as spurious. If she has 3 prolactin levels without any treatment, consider the normal one as the one which you will accept, and the other ones as spurious, especially if her periods are regular. Single measurement of prolactin above reference range confirms the diagnosis. Excessive venipuncture stress to be avoided. Sampling can be done any time of the day now, at least 2 hours after waking up, but then any time of the day. Conditions to be excluded before testing prolactin is excessive exercise. The patient has not come from a gym immediately. She's not taken a Pantocid or a medicine like Zintac in the morning before having the prolactin assessment. Chest wall surgery or trauma, renal disease, cirrhosis, seizure within 1 or 2 hours. Higher levels need to be followed up with pituitary imaging. If you really get high levels persistently, we have to do a pituitary imaging. What are the management recommendations? Only treat symptomatic hyperprolactinemia. And what can prolactin high levels do? Symptoms of E2 deficiency, estradiol deficiency, irregular menses, galactorrhea, or fertility desired. So this is what high prolactin levels will do for a patient. With irregular menses, she may have symptoms of estrogen deficiency, which means vaginal mucosa starts getting atrophic, it is drier, intercourse becomes difficult, her bones start becoming osteoporotic. So if all these things are happening with irregular menses, she needs treatment. If galactorrhea is there, she needs treatment. And if she desires fertility and there is the prolactin is responsible for her ovulatory dysfunction, then she needs treatment. Young women with menstrual irregularities from hyperprolactinemia to be treated either with dopamine agonist if she tolerates them well, or oral contraceptives. So the dopamine agonist dose should be adjusted so that she starts having regular periods if she's got prolonged oligomenoric episodes. Or you can just replace it with oral contraceptives, because they might replace the estrogen also, which is deficient. But nowadays, we do not consider oral contraceptive for estrogen replacement. We like to give micronized estrogen followed by a progesterone withdrawal for these women. Then galacturia, treat with dopamine agonist irrespective of the prolactin levels. Now, suppose a woman comes and she says, I simply hate, I'm secreting milk from my breast. You do a prolactin level and it comes to 18 or 20 or 12. What do? You tell her, no, your prolactin is normal, go. I don't know why you're having see whether she's got injury on her chest, whether she's got renal failure, liver failure, anything like that. And if there is nothing of that sort, please treat her, or she's on a drug intake. So many times we find that they're taking antipsychotic drugs or medicines for hyperacidity and regurgitation, and that is the reason for high prolactin levels. So if there is no drug intake, there is no chest lesion, there is no failure of renal function, then whatever prolactin levels are there, suppress them further, because you have to suppress a galacturia. It is a high nuisance value symptom for a patient. So you have to take the prolactin levels to such low levels that her breast stops being active to whatever levels of prolactin are there, because estrogen priming determines what prolactin levels are required to secrete milk. And you take it below that and she will stop having galacturia. And if it is leading to anovulation and infertility, manage with dopamine agonist. Those failing to ovulate with dopamine agonist may be considered for ovarian stimulation with gonadotropins, not with oral ovulation inducing agents, because these prolactinemic women behave like hypogonadic women. So we need FSH and LH both to stimulate these women. How do you give dopamine agonist? Either you start bromocriptine or you start cabergoline. Bromocriptine I used a lot in my days when cabergoline was not there, and the dose is 5 milligram a day in divided doses. 66% will respond. If you start 7.5 milligram a day in divided doses, 90% will respond. And 10% will need a higher dose than 7.5 milligram. We can even, or it can be given once. 10 to 15 milligram a day is rarely required, and I have used it in some patients in the days when we had no cabergoline. Cabergoline, the starting dose is 0.25 milligram twice a week to a maximum of 1 milligram twice a week till ovulation is resumed. How do you know ovulation has resumed? Follow-up resumption of ovulation by serial progesterone levels weekly from day 21 of the cycle. So you would know if she's not ovulated after 3 P4 levels weekly, that means in 6 weeks, you have to increase the dose for the patient. Gonadotropins, when you use, it has to be a combination of FSH, LH as used in hypo. High prolactin levels do not hamper pregnancy rates by effect on ovarian or endometrial function. So even if prolactin levels are high and you stimulate her with gonadotropin, she will ovulate and it will not hamper her becoming pregnant. So follow-up has to be done. If you are using bromocriptine and cabergoline, from 3 weeks onwards, you do the P4 levels. If she doesn't ovulate within 5 to 6 weeks, you have to go on increasing the dose every week till you find that she has ovulated. And then that dose is kept constant for her, and she's asked to have natural regular intercourse 3 times a week, and she should come back pregnant. Now we come to the third intrigue problem, congenital adrenal hyperplasia. It is of 2 types, classical and non-classical congenital adrenal hyperplasia. So diagnosis of classical, is it classical? I can't see. I need to, okay. Non-classical. So I'm leaving it like this only for this slide. I'm not bringing it on slideshow because I want to read the footnote, what I've written with it. This is puberty onset and presents like PCOS, symptomatic, screen with early morning before 8 a.m. baseline serum hydroxyprogesterone measurement in menstruating women. You have to sample in early follicular phase. So what is it? If the patient is symptomatic, she's got hirsutism, she has irregular periods, doesn't have periods, then you have to screen early morning before AM. Baseline serum hydroxyprogesterone has to be done. Needs to be measured. And if she's menstruating, oligomenstruating also, then it is best to do it in early follicular phase. Individuals with borderline 17 hydroxyprogesterone level, co-syntropin stimulation test is recommended. And you do a genotyping, or in other words, I would say you do karyotyping only if you want to do genetic counseling or when diagnosis is in doubt. Although random 17 hydroxyprogesterone concentrations are usually diagnostic in classical form of CAH, sometimes they may be within normal range for individuals with non-classical CAH. Thus, the acute ACTH stimulation test remains the gold standard to confirm decreased 21 hydroxylase activity. Following collection of a blood sample to measure baseline hormone concentration, synthetic ACTH, which comes by the name of cortrosine, 0.25 milligram is administered. A second blood sample is collected 30 and 60 minutes later. Correlation of hormone concentrations with genetic analysis has suggested that mutations are likely to be identified on both alleles when the ACTH stimulated 17 hydroxyprogesterone value exceeds 1500 nanograms per DL, although a few NCH, non-classical CH patients, particularly if older, would demonstrate ACTH stimulation 17 hydroxyprogesterone levels between 1000 and 1500. So I'm just giving you a idea that a level which is like around 10 nanograms will go up to 1000 nanograms also if you give a stimulation test. And this is very important for us to know whether she is really a patient of CAH. Now, phenotype, I wouldn't say genotyping means karyotyping to be considered only for purposes of genetic counseling or when diagnosis is in doubt. I'll tell you why we do it. So when we talk about non-classical CAH, management recommendations are asymptomatic non-pregnant women with non-classical CAH, no treatment. If she's not pregnant and she's got no symptoms, that means her periods are almost regular, she doesn't have a lot of hirsutism, you do know nothing. You may not even diagnose her to have CAH. But if they present with hyperandrogenism and menstrual irregularities, you can manage them with oral contraceptives. You don't need to give anything. You manage them exactly like you manage your PCOS women. Infertile women with anovulatory infertility or with history of miscarriage, treat with glucocorticoids which don't cross placenta. So which is the one which doesn't cross placenta? This question I've left for the audience, they will answer. Infertile women who fail to ovulate with glucocorticoids may be treated with oral ovulogens or controlled ovarian stimulation with gonadotropin. Here you treat them exactly like PCOS. You can give clomiphene, you can give letrozole, or you can give them FSH or FSH-LH combinations in gonadotropins. Now, fetal transmission, women with classic CAH and non-classic CAH do not transmit the disease to offspring. Please understand, unless the partner is a carrier or is affected. So, karyotyping of the male partner may be done for genetic counseling. Since CAH is an autosomal recessive gene, both the mother and father must be carriers of CAH for a child to have CAH. So, if a woman has CAH and you've done a karyotype and you found that she has autosomal recessive gene, then the only thing is that when she gets married, her husband can go through the same test, and if he doesn't have the autosomal recessive gene for CAH, then just don't bother about the child, because the child would be a carrier again or would be free of disease. He cannot have the disease unless there is one gene from both the parents which come. And if there is a recessive CAH gene in both the parents, then the option to prevent CAH in their offspring can be through PGT. Classic CAH, well, these are the ones who don't present to us. They are already diagnosed in their childhood or in the neonatal period by the pediatrician, but they come to us when they are pregnant or they are trying to get pregnant. So if they are on dexamethasone, it is to be substituted with hydrocortisone or prednisolone. Women with classic CAH when pregnant should be continued on pre-pregnancy doses of glucocorticoid and mineralocorticoid. Whatever they were taking pre-pregnancy, dose adjustment should be done if symptoms or deficiency occur, and here an endocrinologist needs to be involved. So the last and most important is gestational diabetes mellitus, Indian guidelines, November 2009. Why I've taken this, though this is a pregnancy problem, but it starts before pregnancy only. So we all understand that universal screening for GDM is essential in pregnancy. Women of Asian origin and especially ethnic Indians are at higher risk of developing gestational diabetes mellitus and type 2 diabetes. So hemoglobin A1C levels during pregnancy generally should be 5.3% to 6%. First screening in the first trimester. If normal, then you can do a glucose tolerant test again around 24 to 28th week and finally around 32 to 34th week. So first screening is in the first trimester. If the hemoglobin A1C is normal, then the next test comes on the 24th week where the fetus starts making his own insulin and a high blood sugar of the mother would be transmitted to the baby. And the baby would make more insulin if that blood sugar goes to the baby. And then finally, about 8 weeks before delivery, so that we can control the sugars if they are high. Now, diabetes with infertility. How do we see what is to be done? Glycemic criteria for diagnosis of different categories of glucose intolerance by a 75 gram 2-hour OGTT. Normal glucose tolerance is less than 100 fasting and less than 140 2 hours post glucose. What is impaired fasting glucose? When it is in between 100 to 225. What is impaired glucose tolerance? When it is 140 to 199. Fasting may be normal. In that, the 2-hour post glucose may be normal. So impaired fasting glucose is when the fasting is impaired. Impaired glucose tolerance is when the post glucose is impaired, and diabetes mellitus is there when both are in the wrong level. That means fasting is high and the 2-hour post glucose is high. So you say impaired glucose tolerance, impaired fasting glucose, or impaired glucose tolerance if fasting and 2-hour post glucose both could be impaired, but fasting is less than 125 and post glucose is less than 200. So this is how we would diagnose GDM during pregnancy. I think you can take a picture of this, which I've taken from the chapter. And goal is to keep hemoglobin A1C to less than 6.5% throughout the pregnancy. Now, a single test procedure to diagnose GDM in pregnancy, women are given 75 gram oral glucose without regard to the time of the last meal, a blood sample collected at 2 hours for estimating plasma glucose. It is GDM, that means gestational diabetes mellitus, if 2-hour plasma glucose is more than 140. Now, what are the advantages of this test? Pregnant women need not be fasting, least disturbance in a woman's routine, serves as screening and diagnostic procedure, simple, economical, and feasible. However, 75 gram of oral glucose is not tolerated very easily by women in pregnancy, and 2 hours waiting also may not be very practical for most of them. So a lot of people switch over to 50 gram of oral glucose and do a 1-hour glucose sample, which again has the same criteria that it should be less than 140. If it is more, then she needs to be careful about her diet. Coming to the last slide, the WHO criteria for gestational diabetes is this. You say diabetes when the 2-hour plasma glucose in an oral glucose tolerance test. This is not again this is a fasting one. Is diabetes when 2-hour one is more than 200? When do you call it intolerant impaired glucose tolerance? It is when 2-hour is more than 140 but less than 200. Then it is gestational glucose intolerances when 2-hour is more than 120 and less than 130. And if 2-hour 2-hour one fasting is less than 120, then in pregnancy or also it is normal, and outside pregnancy also it is a normal glucose tolerance test. So all I want to say is that if you do a OGTT, oral glucose tolerance test, then above 200 is diabetes, between 140 to 199 is either intolerant, matlab if she's not pregnant, then you call it as impaired glucose tolerance. If she is pregnant, then you call it GDM. And if it is less than 120, it is normal. So we have to just be very careful about this. When is it gestational glucose intolerance? When the levels after 2 hours are between 120 to 140. So we have to be careful when we do 75 gram after 2 hours when the patient is nil orally. So it is important to do this. Having said that, the take-home message is initial screening should be done with T4 TSH. Infertile women reference range is same as non-pregnant women, but if treatment needed, maintain TSH to less than 2.5. Pregnant women, the reference range changes to less than 2.5. Only treat overt hyperthyroidism. So if there is hyperthyroidism, try to prevent the medicines. Only give if really T4 levels are high. Ensure hyperprolactinemia as the cause of anovulation and treat with dopamine agonist or gonadotropins. Discard higher levels with good ovulation as macroprolactinemia. Symptomatic non-classical CAH and fertility not desired, treat with OCPs. For ovulation, treatment with glucocorticoids or ovulogens. The non-classical CAH offspring only affected if both parents are carriers. So congenital and classical and non-classical offspring only is affected if both parents have the autosomal recessive gene. And infertile women with diabetes mellitus type 2 aim at hemoglobin A1C levels to less than 6.5, and for gestational diabetes less than 6. Thank you. Thank you. Let me
Thank
see
you,
in the
ma'am.
chat what is coming. It is so exhaustive, this thing, no? And to
I
cover.
know this, it was to cover all four topics in our talk was really exhaustive. And ma'am, as usual, we learn so much from you. We have few questions, I think, related to the prolactin levels. So Richa wanted to know if the adenomyotic uterus produces local prolactin,
I
or
don't know,
is there any
Richa. I don't
correlation
know.
between
Someone else will
adeno?
have to give you an answer to this. I have absolutely zero idea whether adenomyotic uterus produces local prolactin and whether it would do anything bad to the pregnancy. So someone else can answer. Please unmute and answer. Anyone out of the people who are here? Let me see who all are here.
Just now, when I was looking for it after the question was asked, I just found a case report, ma'am, wherein they have said that probably there is a correlation between high prolactin levels and incidence of adenomyosis of the uterus,
Okay.
and
So
controlling the
it is
prolactin
vice
levels might.
versa. It is vice versa then. I mean, she's asking whether
Yes,
adenomyotic uterus produces local prolactin.
produces local
But you are
prolactin,
saying that prolactin levels high might lead to more incidence of
incidence of
adenomyosis. Richa, is
adenomyosis,
that true?
and
What is it?
controlling
No,
the
ma'am.
prolactin levels might treat the adenomyosis.
No, ma'am. It's good evening, ma'am.
Good
Ma'am,
evening.
what I know is, matlab, what I have recently read somewhere. I might share you with a paper about it.
Yeah, very
It is
nice.
said that
Sure.
adenomyotic cells in the uterus they have lactotropic activity. So
Okay.
when we do an
Okay.
embryo transfer in such uteruses, despite being an FET, there is certain activity of these adenomyotic cells which causes failed
Okay.
implantation.
Oh,
So this was
can
That
there.
you
could be a
send this paper
pathophysiology
on the
of
forum? We will all read it.
adenomyosis. Yeah, I think that could be one of the pathophysiology of adenomyotic uterus leading to implantation failure, probably. But
Yeah,
I don't
and
know how would
they
we
have
treat
But
that.
I've never read about it,
mentioned
Richa,
that
and I would be very happy if you could put the paper on the forum and we will all read it. Then we'll know really
Right.
what is the correlation and whether high prolactin levels need to be. I mean, what will we do if it is only local production and the normal
Absolutely. Yeah.
prolactin levels are normal in blood? Should we treat? How do we treat? What do we do? We reduce the
yeah,
adenomyoma
sure,
or
ma'am.
we
I'll try
reduce
to
the
retrieve
prolactin
it
level?
again. Yeah, ma'am. Okay, ma'am.
Yeah. So
And
you
Nayana wants to.
put it on the forum and we will all read it. What is the next
The next question
question?
is Nayana wants to know whether there is any role of repeat prolactin
Yeah,
levels
Nayan, is
while treating
there any
hyperprolactin.
role to repeat prolactin while treating hyper?
There seems to be a disturbance in your connection, ma'am. Can't hear you.
normally we do this because your main aim is to give her dopamine agonist in a dose which will induce ovulation for her. It will suppress prolactin to a level where the pituitary hypothalamic axis will be re-established. So you just have to do it with progesterone levels and not look at prolactin levels really. How long to give depends on how long your patient is ready to wait. I mean, in men with hypo, they are ready to take 6 months of injections. Here, I think you have to give it for 6 weeks. If she doesn't ovulate in 6 weeks, there is no progesterone rise, then the best is to increase your dose or add up gonadotropins. What is everyone's opinion on this? Tell me. Anyone wants to comment on this? So no comment. So what I have learned is, because I used to use a lot of bromocriptine in the earlier days, and the only way to monitor was progesterone levels after 3 weeks every week. And another thing you can see is the cervical mucus if you don't want to do a blood test. And if the cervical mucus at any time looks non-estrogenic, then you know that
She
that
doesn't
has,
ovulate because of
yeah.
yeah.
How long to give? That is, then what is hydronena? What are you asking about hydro?
Ma'am, that was the answer to your question when you asked
Okay.
that which
Yeah,
is
yeah.
the
Very good.
steroid doesn't cross the placenta.
Yeah, prednisolone is the treatment of choice for girls where you want to induce ovulation or you want to give it in early pregnancy. I mean, we don't need to give prednisolone in early pregnancy unless they are already the ones who have had a CH from childhood and they are already on replacement therapy. There you need to give prednisolone in pregnancy. For others, you don't need to give anything.
The next question is from Dr. Bhagyashree. She wants to know whether the 75 grams OGTT and HbA1c is added to the first trimester screening in ANC patients.
I really don't know, Bhagyashree. Tell me whether we should be doing both. A lot
I
of
think,
my
ma'am,
colleagues
since
do.
Indian population is considered to be a high risk zone, so we are, we are Caucasians and with
But
a
in the first
Indian
trimester, you
origin.
cannot do a 75-gram OGTT. The patient is so nauseous, she's vomiting so much. In fasting, if you give her 75 grams, she'll vomit it all out. So it's very difficult to do it. So I'm
Ma'am,
not sure.
current guidelines say, ma'am, in high-risk patients with a family history, with history of
History.
PCOS, obesity, or with previous macrosomic baby, if there's
And
any
in fact,
high-risk
ma'am,
factor, then we should do
Indian
75 gram
Indian
OGTT.
origin women are considered high risk as it is
Okay.
because of their
So
Caucasian.
we should be doing, which we don't do because most of our patients are vomiting and they have so
Yeah.
much nausea. So, but it's important to do a fasting sugar at least. If she can tolerate, I think we can do a 2-hour later sugar after 75 gram of glucose. What say everybody? My practice is I just do one random sugar and I do a hemoglobin A1C. But in obese women, I think it is important to do a OGTT. And as Bhavani is saying that all Indian women, if they have a family history, should have it. And as Tejashri is saying that Indian women all are high risk. So we should have it for all. We don't do it. Who does it as routine? Rachna, do you do it? Nisha, do you do it? Nisha, Rachna, I can see a lot of very senior girls here. Do you
No,
do
ma'am. In
OGTT?
first trimester, we don't do OGTT, ma'am. If the patient is high risk, then we can go with fasting and 2-hour PP. If the previous history of GDM and high glucose level in last or already diabetic patient.
कौन बोल रहा है आप नाम बताओ अपना
Nisha, ma'am.
Okay, so what you're saying is very correct because getting OGTT done for all girls could be quite difficult. So if there is a history, she's obese, she's PCOS, I think it's important to do it, right?
Yes,
What do you
ma'am.
say,
Right.
everyone? So PCOS, obese, age, history,
Previous,
family history.
previous GDM history and already
Yes.
diabetic type 1. Then we
So
can start with HbA1c fasting and PP.
So can we give her antiemetic before she takes her glucose. We take a fasting sample, give her a dose of MSET, and then give her so much of glucose to drink. Because lot of my girls came and they said we were vomiting. हमने आधा तो उल्टी कर दिया.
That's why we don't go for OGTT in first trimester, ma'am.
Yeah, it's very difficult in first trimester. So anyways, but the guidelines say that we should be doing it, right?
Yes, ma'am.
Huh?
So, ma'am, good evening. I'm Rachna.
Yeah.
Ma'am, I asked them to make like lime water out of it. You can squeeze a lemon
Yeah,
and
this all of them
and
do.
keep it over
They make
15
lime
minutes.
water only. They put
Keep
nimbu
it over,
in
then
it.
they're able to somehow manage, ma'am.
Okay.
Or one odd patient refuses, but then most of them are able to manage that way.
So, this is one thing which all the laboratory people are doing. They make a nice shikanji out of the glucose which you give them. But I wonder that only in high-risk patients, maybe it is important to do a OGTT, but otherwise hemoglobin A1C, one random sugar or one fasting sugar might give us a fairly good idea about their status of sugar. What does everyone feel? That one
Right, ma'am.
fasting or a random sugar, either of the two or both of them, or hemoglobin A1C should be able to identify the borderline cases, right?
Right, ma'am.
Anna?
Ma'am,
So,
moving on to the next question. The next question probably is related to the same thing, that will we do the 75 grams thing in high risk patients? Related to hyperprolactinemia, Dipti wants to know whether if a patient has conceived with treatment on cabergoline, should we switch from cabergoline to bromocriptine once she conceives, and how long to continue in pregnancy?
Deepthi, now there is enough evidence to say that cabergoline is as safe as bromocriptine, and hence they can be continued on cabergoline, but you don't need to continue unless she has a macroprolactinoma. And if the levels were so high that you had to give her bromocriptine, once she conceives, then you can just in the initial part give her a little progesterone support. Once the placental function comes up after 7 weeks, you don't need to give any bromocriptine or cabergoline unless she has a micro or macroprolactinoma. And in those cases, it is not bromocriptine which is recommended or cabergoline. How do you see? Because prolactin levels become high in pregnancy. So it is the visual fields which has to be seen. And if it is a macroprolactinema, then you may have to do a MRI during pregnancy if the visual fields get impaired. So if it is without a micro or a macroadenoma, you don't need to follow up prolactin levels. You don't need to give bromocriptine. You don't need to give cabergoline. You give nothing. You just make sure that in the early first trimester, for first 7 weeks, there is no progesterone deficiency. Once the placenta will take over, nothing is going to happen. Is this clear?
Yes, ma'am. Understood.
And like you've written, if patient's prolactin is 110 and pituitary imaging is normal, and you've started with cabergoline and the patient has conceived, just relax. Give her progesterone for the first 3 weeks of pregnancy. Once the cardiac activity is there, placenta is formed, forget everything. No cabergoline, no bromocriptine. If there is a micro or a macroadenoma, you can follow up with visual fields, mostly with macroadenomas. Even micros sometimes grow during pregnancy, so you can do a visual field every trimester or maybe earlier also in a macroprolactinoma. Enough?
Ma'am, I had one case yesterday evening in my OPD, so I just wanted to ask what your approach would be to this girl. She was a 21-year-old girl with irregular menses, delayed cycles of about 45-60 days since menarche. And she told me that she had been diagnosed with PCOS and had taken about 3 to 4 months of oral contraceptive pills with which her cycles were regular.
Right.
Now, she had come to me because she said that since last 6 months, I have been gaining weight rapidly, and she used to use a shaver for her hair on the hands and legs. So she said my shaving frequency has increased a lot. When I looked at her, she had this, typical moon facies, a buffalo hump, and she had a lot of stretch marks on her body. So appearance-wise, she was looking like a typical Cushing's, facies and the appearance. So Now, ma'am, how do we go about it? I have ordered 17 OHP and
Correct.
DHEAS and testosterone and all of that. But
Hmm.
then, is there any challenge test, or how do we really approach this?
There's
And also, yeah, one thing to mention, she had a hypertension. So her BP was about 170, 110 in my
So I
OPD,
think she's the
and
right patient whom you should refer to
her
an
sugars were
endocrinologist.
also deranged.
You have to refer her to an endocrinologist. Either she has
Hmm.
metabolic syndrome or Cushing syndrome. And metabolic syndrome, already you're saying she was obese, she has
Yes,
mm, she has a hump, and I don't know
yes.
whether she had stria in her neck or not, whether you looked for that.
She had acanthosis. She had stria almost all over the
तो
body.
उसको
So
metabolic syndrome तो
shoulders
है
and
ही उसमें, metabolic syndrome तो है ही. So
But
maybe Cushing is there, so you need to refer her to a proper endocrinologist, Tejashri.
right,
And उसमें
right.
मैम सीरम कोर्टिसोल भी कराते हैं ना, सीरम
Yes,
कोर्टिसोल.
early morning.
Serum
हाँ, हाँ.
cortisol baseline morning I have ordered
Yeah,
fasting
correct.
cortisol. But
Before 8
those,
o'clock.
yes, I've told her
हाँ.
at 8 o'clock, like
So you can see that in
before.
17 hydroxyprogesterone भी order कर दो. So you
Hmm.
will get a comprehensive idea of what it is. Looks like less
Hmm.
likely CAH and looks like more likely maybe Cushing's or maybe just metabolic syndrome
Metabolic syndrome with PCOS.
with PCOS. Yeah, these two are very commonly combined diagnosis. PCOS, a lot of PCOS have metabolic syndrome. In fact, a lot of girls with pure metabolic syndrome, we take them granted as PCOS, but then you find no hirsutism, very nice skins, and regular menstruation, but obese and all other symptoms like hypertension is there, hyperlipidemia is there, sugar might be high, everything is there.
Right. Anyone wants to ask any question can unmute, and we have 2 minutes more to go.
Ma'am, I have a question. Ma'am, in a patient with hyperprolactinemia with no ovulatory dysfunction, with unexplained infertility, would you like to treat her, ma'am, or not? Does
No.
it cause luteal phase defect
This
also?
was the thought, especially when experiments on mice were done. But then later on, they found that luteal phase deficiency happens, does not happen in matlab in females. Yet you can sort of maybe give her a progesterone support, but not treat her with cabergoline or dopamine agonist, any other agonist. You don't need to treat her with anything. If she's ovulating, all you can do is maybe give a progesterone support in the luteal phase. That we also give with normal prolactin levels. So please do not start her on cabergoline. This is an expensive drug, and it has other profound effect also if it suppresses the pituitary gland to some extent.
Ma'am, in patients with subclinical hypothyroidism, if they are anti-TPO positive, then how frequently would you monitor their thyroid profile, ma'am?
If they are pregnant or non-pregnant?
In pregnancy, ma'am, if not anti-TPO, then at least in every trimester we do. If
Yes, but
anti-TPO
TPO
positive,
maybe every 3 to 4 weeks you can see them. The recommendation is every 6 weeks. When I read
okay.
over here, the recommendation was every 6 weeks you need to follow up, but not TPO. If you are giving TPO positive and she is on replacement, Eltroxin replacement, every 6 weeks. Otherwise, every trimester follow-up should be good enough if TPO is negative. So
Ma'am,
we are
I wanted to just ask a question, ma'am.
Yes.
I wanted to ask regarding the dydrogesterone dosage. Actually, we prefer a 10 milligram TDS dose in especially high risk patients who have recurrent pregnancy losses or as a luteal phase support. I wanted to ask, madam, nowadays we are getting some sustained release preparations which are being promoted more so for endometriosis. And they also, I mean, suggest that it has the same effect as a 3 times dosage. So would you recommend, ma'am?
Who's asking this question? Can you identify?
Bhagyashri, ma'am. I'm Bhagyashri from Nagpur. Tejashri's sister, I can say.
Okay.
Yeah.
Bhagyashri, I'll tell you one thing. The pharmaceuticals have to survive.
Yeah.
And the market is growing. They have to come up with new ideas and new drugs. Doesn't
Yeah,
mean
ma'am.
we as doctors treat our patients like guinea pigs and start using all those drugs on them
Yeah,
unless
ma'am.
we feel very sure that yes, this will work. Another thing is dydrogesterone. I don't use in my luteal phase support because I feel it is a synthetic progesterone. Whatever said and done, it is a retroprogesterone, but it is synthetic, and hence I would rather use a micronized pure progesterone for my patients. I would sort of keep away the dydrogesterone unless I'm compelled to do it. The patient cannot use a vaginal tablet or has infections or has problems that she cannot use a vaginal tablet. And then I wouldn't want to use any oral steroids because whether it's dydrogesterone or it is progesterone, when you use it orally, it goes through the liver pass.
Yeah,
And the
definitely.
liver is definitely affected by all steroids, whether they are estrogen, progesterone, or corticosteroids. So I refrain from using any oral steroids. I mean, even Progenova now I've learned from all of you that I can use vaginally for patients where we have a little liver dysfunction or any other problem. So
Yeah.
it's better to use a vaginal progesterone. If you counsel your patient, she will listen to you.
Yeah, ma'am. Even we nowadays get progesterone gels, which are a bit,
Yeah.
yeah, ma'am. Those are a bit comfortable for the patient to use than
Yes,
the
you can use
tablets.
just
So
once
these,
every
yeah, ma'am.
night, the
Once
dose of
every night.
gels. And
Yeah,
vaginal
ma'am.
tablets you can use twice. So,
Twice.
I would prefer 3 times oral dydrogesterone. Take one tablet and see how nauseous you get.
Yeah,
3 times
definitely.
makes the patient very nauseous. And 3 times is not the dose. I mean,
Yeah,
2
ma'am.
milligram is more than enough if you want to use it.
Okay, ma'am. Okay.
All
Thank
right.
you
Thank
so
you so
much, ma'am.
much,
Yeah,
Dr. Abha.
definitely.
Ma'am, it was always a pleasure to listen to you, and we are all in awe of the effort that you're taking to enlighten us with all the knowledge that you have. Hope we are
Yeah, I
able
sometimes
to.
have to read before I take it because
Absolutely.
I have to
Thank
just
you so
read the
much.
whole thing.
On behalf of all the girls that
Thank
join
you.
our classes, thank you so much for all the effort that you take for all of us.
Thank you. Thank you,
Thank you,
everyone,
ma'am.
for
Bye bye.
joining and
Thank you
listening.
so much, ma'am.
I'm so happy teaching, because I get an opportunity to revise what I know and I learn so many new things from all of you. Like today, I've learned that adenomyoma, I will go and look into it. And you will also put that what happens if prolactin is high on adenomyoma or what happens if adenomyoma is there on levels of
So we
prolactin.
can do a prolactin levels on patients who are RIF with adenomyoma. We can do that.
Yes,
We
and
can
you
just
see,
find out what their
all
levels are.
right.
Right, ma'am. All
Thank
right.
you.
Good night, ma'am.
Good
Pleasure
night.
always. Thank you.
And again, I won't forget to thank Vishal Dave for being there as the first person who joins the meeting. Vishal, extremely thankful to you for giving us this platform. We don't have to spend anything. We all are sitting in our homes or clinics and we do this little educational exercise. Thank you so much.
Thank you, ma'am.
Okay.